So I have mentioned that in the diffuse large B-cell lymphoma, and in this particular case, it was the germinal central B-cell-like phenotype. We can discriminate 2-3 subtypes of diffuse large B-cell lymphoma. One is germinal central B-cell-like, the second one is ABC, and the third one is just the intermediate subgroup of patients, or not defined subgroup of diffuse large B-cell lymphomas. This discrimination was based on the molecular biology, on the gene expression profiling. But for the routine practice, the immunohistochemistry seems to be the most useful approach, more practical approach. So there are several attempts how to translate these molecular biological findings into the immunohistochemistry. There have been described several systems how to discriminate GCB versus non-GCB subtypes. We use the Hans algorithm, and what we can say that this algorithm can discriminate between 2 subtypes which have a different prognosis. GCB usually have a better prognosis compared to the non-GCB subtypes. The other issue in this patient was that this patient has a high Ki-67 proliferation index, which is not very usual. As you probably know, for instance, the Burkitt lymphoma have almost 100% Ki-67 proliferation index. And it means that these cells are very rapidly dividing and they are very active. Usually we can nowadays check other molecular features like translocations. For instance, one subgroup of diffuse large B-cell lymphoma, so-called double-hit B-cell lymphoma. In this lymphoma, there is a MYC translocation together with a translocation 14-18 or with some other patterns. And this particular subgroup of patients have very poor outcome.